Good morning, everybody, and welcome to this talk on cervical cancer, which was prepared for Sydney, refined for Paris, and finally delivered from my home in London for our virtual ISMRM meeting. Welcome in whatever time zone you're sitting in. I have no financial interest to declare. So over the next 30 minutes, I'm going to talk about the epidemiology, screening, pathology, management and MRI techniques by way of introduction, then move to MRI in staging as a management decision support tool, MRI for prognosis, and finish up with MRI for surveillance and follow-up. Cervical cancer is preceded by a well-defined pre-invasive stage called cervical intraepithelial neoplasia, which occurs 10 or even 20 years before the disease is manifest. Abnormal dysplastic cells from the outer layer invade into the deep tissue layers. Depending on the degree of dysplasia, cervical intraepithelial neoplasia is graded as 1, 2, or 3, with higher grades progressing to invasive cancer. Lower grades may regress, but may also progress to higher grade cervical intraepithelial neoplasia and then to cancer. The recognition that HPV, human papillomavirus, was a causative agent in cervical cancer gained Harald Zuhausen a Nobel Prize in 2008. Other risk factors include the number of sexual partners, a history of sexually transmitted disease, low socioeconomic status, and smoking. The biggest preventative strategy is cytological screening. The age-specific incidence peaks in women in their late 20s to 30s, as you see here. That is approximately 10 years after becoming sexually active and acquiring HPV. Mortality, fortunately, has reduced dramatically over the last 50 years because of earlier diagnosis. Most cancers are squamous cell cancers or adenocancers, and a few are rarer subtypes. Management depends on age, stage, comorbidity, and the desire to retain fertility. Both are effective, surgery and chemoradiotherapy, but surgery retains ovarian and vaginal function, so is preferred in younger women. MRI is the mainstay of imaging in cervical cancer, and T2-weighted imaging is really the backbone of assessment. Imaging is done in 3 planes orthogonal to the long axis of the uterus to assess the cervix, and then axially through the pelvis to assess lymph node stations. Diffusion-weighted imaging may complement T2-weighted imaging, but dynamic contrast enhanced imaging is really not required. To ensure the examination is of optimal quality and motion artifacts are controlled, antiperistaltic agents should be administered. It's important that these are administered intramuscularly to ensure they last the length of the examination. An empty bladder is essential. Fasting has been advocated, but compliance is low. The prone position may also help by splinting the anterior abdominal wall, but this is not very comfortable for the length of the examination. So, to staging. Stage 1 disease is where carcinoma is confined to the cervix. 1A is disease that is less than 5 millimeters in depth, and that is further divided into 1A1 and 1A2. Stage 1B disease is recognized clinically, and the division into 1B1, 1B2, and 1B3 disease is purely based on size criteria, less than 2 centimeters, 2 to 4 centimeters, and more than 4 centimeters in dimension. We see here some examples imaged with the pathology correlation, seeing the tumor as an intermediate signal intensity mass with a purplish staining on H and E. Stage 2 disease involves carcinoma that has spread outside the cervix. Here we see the upper vaginal involvement of 2A disease, and incidentally the top right image is a double inversion recovery sequence where the fluid in the bladder and the fat in the posterior parametrium has been nulled to show the vaginal involvement, and 2B disease where there is early parametrial involvement laterally. Stage 3A disease involves the lower vagina, and stage 3B disease the pelvic sidewall. As the risk of nodal metastases greatly increases at these increasing stages, the 2018 FIGO system now recognizes a 3C1 category for enlarged pelvic nodes and a 3C2 category for enlarged paraaortic nodes. Which brings me to the detection of lymph nodes on MRI. The criteria are strictly based on size, short axis greater than 0.8 centimeters, but shape, margins, loss of fatty hilum, and necrosis can also be considered. There are also functional criteria, the most reliable of which is increased metabolic activity on FDG PET. Research studies also describe apparent diffusion coefficient on diffusion-weighted imaging and contrast uptake as other biomarkers of nodal involvement, including negative contrast from ultrasmall iron oxide particles. Nevertheless, in the best hands, the sensitivity for nodal detection on a per-patient basis remains at around 72% for MRI, although specificity is high. Stage 4 disease is where carcinoma involves adjacent organs or has extended beyond the true pelvis. So 4A disease for bladder and rectal involvement, and 4B disease for distant metastases. Fortunately, we only see this rarely in countries where screening is available, but it is still common in the developing world. Now we come to the important piece: how MRI affects management decisions, fertility-sparing surgery versus hysterectomy if surgery is selected, or surgery versus chemoradiotherapy. Where screening is available, a see and treat approach for cervical intraepithelial neoplasia sometimes removes a small cancer. And then the question is there residual tumor? And is the patient eligible for fertility-sparing surgery if she desires it? Here is one such example in a 25-year-old with post-coital bleeding. The tumor is seen on the posterior lip of the cervix, and on the coronal images, on your bottom left, it shows marked diffusion restriction on the ADC map, and this correlates extremely well with the trachelectomy specimen with the purplish staining of the tumor. We do a lot of our assessments in the small stage 1 disease with an endovaginal coil, as the resolution of an external array coil is inadequate even at 3T. This is particularly evident if we rely on the diffusion-weighted imaging, which is essentially low in signal to noise and shown for comparative purposes here. A very noisy ADC map with an external array coil where you can't see the tumor compared to the much better resolution of the endovaginal imaging with this restricted diffusion tumor. And on the sagittal images, there was very good corroboration with the trachelectomy specimen. But just to also show you the limitations, we're also always limited by spatial resolution, and here is one we called negative for tumor on endovaginal imaging because we could see the nice feathery pattern of the normal cervical epithelium really well with no masses, but on the LET specimen there was a bud of tumor just beneath the basement membrane. We're always going to miss disease of this dimension. The utility of using an endovaginal approach in these young women with early stage disease is best summarized in this study of ours on 31 patients, where in the 17 that had no tumor on MRI, seen in the top yellow box, 9 were able to have a cone biopsy rather than more extensive surgery because of their negative MRI. In the bottom yellow box, the 14 that were positive, 1 was small enough to have a cone biopsy, and 2 were too large for fertility-sparing surgery and received chemoradiotherapy as a preferential management option. So management was altered in 39% of cases. The decision for surgery versus chemoradiotherapy really depends on whether there is parametrial extension or not. To exclude this, we really need to see a clear rim of low T2 signal from normal cervix surrounding the tumor, as you see on the top 2 images. Where this is lost and there is streaking of the parametrial fat, as you see in the bottom 2 images, that indicates extension of tumor out into the parametrium. Which brings me to MRI as a prognostic indicator in this disease. This depends not only on stage, as we've just discussed, but also on tumor volume, tumor grade, textural features, which presumably relate to the phenotype of the tumor, and to the volume regression on treatment. Literature linking volume to prognosis, done on the pathological specimen, goes back several decades, and it is more than 20 years since we showed that tumors more than 10 cc's had a worse prognosis. The tumor on the left is much smaller than the tumor on the right and would have a better prognosis. Therefore, providing a volume on our reports should be routine, but is rarely done. We've already discussed staging as a prognostic indicator because of the risk of increased nodal metastases. This slide just reinforces that stage is linked to prognosis, with marked reductions in overall survival for each increase in stage. Grading tumor has always been the domain of the pathologists, but now with techniques like diffusion-weighted imaging, MRI can also now provide a handle on grade. We see here from the left-hand box plot that the ADC distinguishes normal tissue from tumor tissue extremely well, as seen by the area under the ROC curve. But it is also able to distinguish well from poorly differentiated tumor, albeit less well, because there is higher cellular density in poorly differentiated tumors. And histogram plots of a poorly versus a well-differentiated tumor are shown in 2 individual patients, with the left shift of the histogram in the more poorly differentiated tumor. Following on from that, we went on to ask ourselves whether the radiomic features of diffusion-weighted imaging, or even on T2 weighted imaging, were able to tell us whether tumors were poor prognosis or not. As we've just said, volume is a key indicator of prognosis. So we looked at tumors greater or less than 4 cc's, as this is the cutoff volume for fertility-sparing surgery, and asked ourselves how the radiomic features differed between high and low volume tumors. After getting rid of all the correlated features, there were only a handful of features that were different between high and low volume tumors. And you see these on the top left: dissimilarity, energy, cluster prominence, etc. Putting these into a regression model, we were able to show that only 3 or 4 were actually predictive of recurrence. Dissimilarity was a key one, coming up positive on both ADC and T2 weighted imaging. And when we combine these with the clinical pathological features, we're really able to get an ROC curve with a high area under the curve to tell us whether a patient is likely to recur or not. In future, these kind of studies are going to be useful for planning on the extent of surgery and for the need for adjuvant therapy. And finally, MRI provides prognostic information by assessing the degree of tumor regression on treatment. If by the time the patient has received 50 Gray, the tumor volume is less than 20% of the baseline pre-treatment volume, then the outcome in terms of local control, disease-specific survival, and overall survival is better than if tumor volume is greater than 20% of the baseline pre-treatment volume at this point in the treatment. And finally, to the issue of follow-up on imaging. Naturally, this depends on the risk of recurrence, so we need to know the risk of recurrence. We need to know whom to follow up with imaging, where in the body to follow up, when, what time point after treatment. So the risk of recurrence is important in planning a schedule for follow-up. I've listed here the literature on risk of recurrence for patients treated surgically on the left and treated by chemoradiotherapy on the right. For patients treated surgically, for tumors less than 2 centimeters, the risk of recurrence is less than 10%. For tumors 2 to 4 centimeters, it's now approaching 20%, and for tumors greater than 4 centimeters, around 30%. For patients treated with chemoradiotherapy, the risk is higher, naturally, because these are more advanced patients to start with. And just as a rule of thumb, it is around 15 to 20%. A key issue is around how these recurrences are manifest. If they are symptomatic early, then the follow-up protocol would be easy. Image patients as soon as they become symptomatic. But we see from this data going back several decades in the table on the right that a third of recurrences are asymptomatic. This was confirmed in the Danish National Cohort Study, where in early stage disease there was a less than 10% recurrence rate, but a third of patients had asymptomatic recurrence. Surveillance is therefore essential. Moreover, if we diagnose recurrence early in asymptomatic patients and treat them, they have a better chance of survival than if we wait until they become symptomatic. So, where should we image? The retro-embrace study, which was a large multi-center study across several institutions, showed that the majority of patients who failed had distant failure alone, although there were patients that had pelvic failure alone or both pelvic and distant failure alone was by far the majority. And then we also need to know when these recurrences occur to get the timing of our follow-up right. Again, from retro-embrace and earlier studies, the majority of recurrences occur within 2 years. Retro-embrace in fact showed that half occurred in the first year. Of course, later failures do occur, but after year 3, they tend to plateau and are few and further between. So knowing that we need to cover distant sites, we need a sensitive whole body imaging approach, and this is best addressed by FDG PET-CT, which has a high sensitivity and specificity for recurrence detection. A single follow-up PET-CT around the 6-month mark was a good indicator of overall survival. 95% overall survival in those with a complete metabolic response compared to 77% in those with a partial metabolic response. Just some images to finish. Recurrences occur centrally and peripherally. Here are some central recurrences seen after surgery on the left, where the uterus is absent, and after chemoradiotherapy on the right. But not everything that you see as a mass is necessarily recurrence. This young lady had an anterior cervical tumor treated with chemoradiotherapy. This is her immediate post-treatment scan. A year later, she had this large mass in the cervix. It's largely hemorrhagic and represents secretions and hemorrhage from accumulation within the uterine body due to cervical stenosis. This was curetaged and she remained well. Recurrences also occur peripherally on the pelvic side wall, and you can see this rather large and unfortunate one. And another patient, this intermediate signal intensity mass, classically occurring at the nodal stations. And that brings me to a major tip. Always look above the radiation field. Disease within the radiation field should have been sterilized by the radiotherapy. It's the micrometastases that are harbored in lymph nodes above the radiation field that have not seen treatment that are where the recurrences grow. And finally, beware the cervical cancer patient who limps into your scanner room after treatment. This is a red flag for sciatic nerve involvement. This is seen nicely on these ST-R paracoronal sequences, or more recently on these MR neurography sequences, which are essentially just a heavily T2 weighted sequence in 3D with fat saturation. You can see beautifully the involvement of the L5 nerve root on this case, leaving the S1 nerve root uninvolved. These are important issues if the patient is coming to exenterative surgery. And just a reminder that interpretation of the post-irradiated pelvis is often a nightmare because of the hugely edematous soft tissues. There's been virtually no fat nulling on this ST-R sequence, and on this T2 weighted sequence you can see this immense stranding in the pelvic fat. This just shows a possible follow-up schema by treatment modality. I don't expect you to take in the complexity of this scheme, but the key points are that for surgical treatment of tumors less than 2 centimeters, imaging follow-up could focus on symptomatic cases because the risk of recurrence is very low. For larger tumors treated either surgically or with chemoradiotherapy, surveillance is essential. So a PET CT within the first year is important. It could be done at 3 months or 6 months in the case of chemoradiotherapy to avoid false positives from the effects of radiation in the pelvis. And then if that is negative, in high-risk patients and high-risk histology, you could do an annual CT. If histology or the patient is low risk, then maybe no further imaging until the patient becomes symptomatic. It is always key to image symptomatic patients, obviously. So to summarize, MRI complements clinical staging to describe disease extent, parametrial extension, vaginal involvement, local organ involvement, bladder and rectum, lymph node status, pelvic and paraortic lymph nodes. MRI should be interpreted in relation to likely patient management, the type and extent of surgery, is fertility sparing surgery desired, whether chemoradiotherapy is a preferable treatment or whether adjuvant treatments are necessary after surgery or chemoradiotherapy because of patient risk. Prognostic information is available from MRI. Volume is currently very reliable and should be quoted. ADC metrics may give a handle on grade. Radiomics is up and coming, and volume regression also can be done and gives a good handle on prognosis. Follow-up requires whole body imaging because the risk of failure is mainly in distant disease. FDG PET is therefore the best for surveillance. A third of recurrences are asymptomatic and occur in the first 2 years after treatment, so a surveillance FDG PET in the first year in asymptomatic cases is a really useful thing to do. With that, I thank you for your attention and hope to take questions at the live Q&A session. These are my acknowledgements of our funding agencies. Thank you very much.